Give me a second, I will play the video.
Okay. Great day to all of you from all over the world. It is evening here in Asia, daytime in the USA, afternoon in Europe, Africa, and down under, morning in Latin America, late afternoon in India, and evening in the Middle East. It is indeed with great pleasure for us to organize the series of webinars of the Mining Occupational Safety and Health, a subcommittee of the International Commission on Occupational Health, entitled Update on Silicosis Detection and Relief, Sharing Experiences. We have 359 registrants in our webinar today from 48 countries, specifically 14 African countries, 11 European countries, 9 Asian, 9 American countries, 4 Middle Eastern countries, and Australia. This is indeed the goal of our scientific committee, to have a global reach for our advocacies and related endeavors. Mining Occupational Safety and Health, in short MinOSH, is a scientific committee of the International Commission on Occupational Health, or ICOH. We have had a series of webinars, and this is the third in the series. Today, June 29, is our third webinar entitled Updates on Silicosis Detection and Relief, Sharing Experiences. As the chair of MinOSH, I am pleased to give the opening remarks. I am Jinky Leilani Lu, a research professor of the National Institutes of Health, University of the Philippines, Manila. My expertise is on occupational health and safety. I am also currently the chair of MinOSH. First, let me introduce to you our organization. MinOSH, as I said earlier, is one of the scientific committees of ICOH, founded in June 2015 at the ICOH Congress in Seoul, South Korea. The MinOSH Executive Committee was created in Cancun in 2012. MinOSH is one of the newest and youngest scientific committees of ICOH. Let me also introduce to you ICOH. ICOH was founded in 1906. ICOH is the oldest scientific association in the field. It has around 2,000 members from over 100 countries worldwide. ICOH is an NGO recognized by the United Nations and has a close working relationship with the International Labour Organization and the World Health Organization. Recently, on May 27, 2022, ICOH released a statement on protecting the occupational safety and health of migrant workers. Also, in May 2022, the ICOH past president presented the ICOH statement at the 110th session of the International Labor Conference, putting forward that, quote, safety and health is a fundamental right at work. MinOSH, the organizer of this webinar, has as its goals the provision of a rich platform for both theoretical and methodological approaches in mining research and advocacies. It encourages both the science of research and the art of communications for policy statements and advocacies in order to promote occupational safety and health. MinOSH activities are aimed to be multi-sectoral, involving large, medium, and small-scale industries and their workers. Multidisciplinary, involving all disciplines such as medicine, occupational health, allied health, safety engineering, industrial hygiene, social science, among others. Multi-level, both country-specific and global in nature, and multi-strategic as well, covering research, advocacy, extension work, and program policy orientation. This is why we're having this series of webinars for the benefit of our stakeholders. Every worker's life matters. That is our mantra. No one should be left behind in safety and health. Indeed, health and safety is a fundamental right of every worker. Today, we have an interesting array of topics on silicosis, including ILO classification of chest radiographs, diagnostic images for occupational lung diseases, surveillance of silicosis and silicotuberculosis in Thailand, South Africa, and India. You may ask the question, why silicosis? First, silicosis is a global burden. Second, silicosis is not curable as lung damage is irreversible, but take note, it is preventable. Third, there must be concerted national and international efforts to develop systems of surveillance and programs aimed at the prevention of silicosis. All of these must be disseminated, and hence our webinar today. We are indeed honored to be graced by expert speakers who have worked many years in the domain of silicosis as a lifelong career, among others, in order to bring to you, our audience and stakeholders, updates and advances in silicosis. Let us now hear from our esteemed speakers. Professor Narufumi Suganuma is a professor and chief of environmental medicine at Kochi Medical School, Japan. He has special interest in medical screening of occupational and environmental respiratory diseases using radiography and CT, a US NIOSH B reader, and an ILO expert on pneumoconiosis. His interest covers various fields of occupational and environmental medicine, preventive medicine, and international health. To talk on advances in silicosis and diagnostic images for occupational lung disease, Professor Suganuma.
Thank you very much for your kind introduction. I'll try to show my slide. So today's topic is about silicosis, and I want to talk a little bit about diagnostic images of occupational lung disease. For that, we actually going to develop together with the researchers in 7 countries, international classification of occupational of HRCT for occupational and environmental respiratory diseases. So, this is MinOSH. I first heard that it is called MinOSH. But I'm actually I'm serving as a secretary for the Scientific Committee of Respiratory Diseases of ICOH. So probably this is going to be the joint program between two scientific committees. So first slide is showing the case of silicosis. Probably you are very familiar with these images. You have predominant upper zone predominance of small rounded opacities, together with the involvement of the lymph nodes clearly classified. And probably it is easier to show that kind of findings. Probably this is going to be shown by other speaker like Dr. Wiwatana will tell you about the island classification. It would be easier for us all to see the difference between the normal chest X-ray and the damaged lung caused by the dust inhalation. It's more easier to see those by CT as it is cross-sectional, scanning. Will show you the distribution in the lung as it is shown here, and probably you could notice that gathering in the medulla of the lung, and probably the cortex of the lung is a little bit spared, but you could see some dots, opacities on the surface of pleura. As you all know that you would see pleural plaque in asbestos-related disease, but usually you don't have pleural disease in silicosis. But we often see this kind of pleural opacities, and some of researchers or some of the clinicians will call this pseudoplaque, as it locates on the surface of pleura. Usually, the target of the dust-induced diseases is in small airway like this, terminal bronchial or respiratory bronchial or alveolar ducts, and so on. And usually, the dust deposit around this area and causes fibrosis. This is a contact radiogram of the specimen given by Professor Harumi Ito. This shows central lobular location of the dust-induced opacity or fibrosis. You could see the location of interlobular septum, and usually the opacity locates inside the secondary lobule, and so that we call those central lobular opacities. This is the pathological specimen, magnified image. And this is paraseptal opacity, which we saw on the CT on the surface of the pleura. So this is on the visceral pleura. It is not on the parietal pleura, which is the location for the pleural plaque. So this is quite different from what we see in asbestos-related disease. And it is actually the silicotic nodule that locates on the surface of pleura, as shown here. So we all believe in Japan that probably this is because of the abundant lymphatics on the surface of pleura. And this kind of lymphatic network locates in the interlobular septum and also covering the bronchovascular bundle. And this is maybe because of after the phagocytosed dust is brought into this lymphatics, and that may deposit somewhere in the lymphatics and causes that kind of silicotic nodule. This is from asbestosis, and we will add something about asbestosis here. In the asbestosis, we could also see that kind of a small rounded opacity, especially in the this kind of early stage. If it is advanced stage, you couldn't see those, but we could see this kind of finding even in asbestosis, and it attaches like this as a kind of subpleural cavalier line, and it is shown in chest CT like this, and on the left side you could see that the big arrow shows the central lobular opacity. And on the right side, you could see the subpleural cavalier line. Now we are coming back to the silicosis. We have this kind of environmental standard for the occupational setting. And as you see that, US and Japan has a severest level for the occupational exposure limit. In Japan, we have two levels, JSOH, which is Japan Society for Occupational Health, promote this kind of level, which we call occupational exposure limit. And the other one we have is governmental administrative level, which is almost same as that. And we recommend 0.03 milligram per cubic meter. With this kind of a control standard, we see this reduction of cases among the dust exposed workers. As you see that we have the highest level of prevalence, and also highest level of the examined worker in 1980s, and we have a clear decline of the positivity in the dust exposed workers. The panel B shows the complication, the cases of complication. We called secondary bronchitis or secondary pneumothorax, and also TB complications, and also lung cancers, called as a complication for the occupation, the silicosis, and occupational lung diseases. We have, the new report from, the high purity silica exposed workers in the, research institute. 3 cases of accelerated silicosis was reported in the who were handling the high purity silica. One of them died by silicosis. And probably this is a case of, as I said, the accelerated silicosis, as the exposure duration was reported to be 2 to 6 years. And the report said that, the workplace had the 0.05 to 4.8 milligram per cubic meter, which was much higher than the occupational exposure limit or the administrative level for the from the government. That was from Japan, and this is from the international registration for the engineered stone workers. We usually don't have this kind of stones in Japan, I think, but this is the registration from Australia, Israel, and Spain and US. They gathered some 169 cases and showed the chest image findings here, and it shows simpler silicosis was predominant, but they experienced many cases with complicated silicosis with the progressive muscle fibrosis, and other findings like gland grass opacity and mediastinal adenopathy was found. So, I may want to add here that, autoimmunity was reported 21% among these population. And probably this kind of issue was reported somewhere, but probably this is a new topic about rather new topic, or probably we need to dig into that more into detail in the future. And also they actually use our city classification. So I will just add something about the city classification. We have many revision for the IRO classification, and we actually propose on the course for the similar classification using HRCT. So this was revision going on, and we are going to get newest version very soon. And the CT application for the occupational lung disease started in the 1970s using CT for the detection of pleural plaque. And in 1982, Japanese researcher developed HRCT. Kyoto University researcher developed this kind of new technique. And this is applied to diffuse lung disease, which can be applied to pneumoconiosis, which is also diffuse lung disease. So there's two CTs, spiral CT for the detection of lung cancer, and also there's the HRCT classification for the description of diffuse lung disease caused by dust. So after the Helsinki meeting in 2000, we developed the research group with the 7 countries researchers, and we proposed international classification of HRCT for occupational and environmental respiratory diseases. We use HRCT, but some of the discussion led us to use a low dose HRCT, which can be applied to the health workers. So this is the specification of the technique is described in the Scandinavian Journal of Environmental Health, which actually summarized the report of Helsinki criteria. We actually gathered together with the Finnish and Germany and the UK, the US, and the Belgium and the France researchers, and gathered together to merge 3 classification systems, Finland and Japan and Germany system. And we developed this HRCT classification system, which covers rounded opacity and regular opacity and other findings like ground glass, honeycombing, and emphysema, also large opacity and pleural abnormalities. And this is quite, coincidentally, almost the same time as the ATS guideline for the non-malignant asbestos-related disease guideline was revised. And this guideline shows a quite important role for the imaging method. How many minutes I have? I think I'm almost running up my time, but I will continue some other slide. And as this guideline shows, the evidence of structure change and the evidence of plausible causation can be detected by imaging method. If you have a proper image, you can actually detect asbestosis only with this plain chest X-ray. As you see that on the chest X-ray, you can see irregular opacity and the lower zones, and also you can detect on the left side of the pleura, you could detect a calcified plaque. So you could detect this as asbestosis. And this is actually the summary of what we actually updated from the 1997 and the 2000 version of Helsinki criteria to the 2014 version of the Helsinki criteria. We actually recommended the use of screening of asbestos-related lung cancer using spiral CT, and also follow-up using ICOH-MinOSH. So probably we can look at this. And our CT classification is used as a national standard for in Germany. And also we actually IC or IC something ICO scientific committee for the respiratory disease made this kind of statement for the global asbestos ban and the elimination of asbestos-related diseases, referring to this kind of a project with the CT classification. And we were invited to the LCAP study. They were using our classification system. So this is the end of my topic. Recognition did the first, though it cannot stop the new cases. Thank you very much.
Thank you, Professor Suganuma, for your informative and in-depth talk. As was mentioned by Dr. Suganuma, we are looking forward to the new version or the updated version of the ILO classification based on expert recommendation of scientists such as Professor Suganuma. Secondly, there is really a need for cross-indexing and harmonization of classification of silicosis and other occupational lung diseases. And thirdly, diagnosis and surveillance system, including classification, are important parts of silicosis control program. Now, some mechanics for our webinar. We have a total of about 5 speakers. Each speaker will talk for 17 minutes, and then we will proceed to the open forum. Should you have questions or comments, please type in the chat box or fill out the Google form provided in the Zoom. Please identify yourself and the organization that you represent. Dr. Wiwatana Tanomkiat is an associate professor of the Department of Radiology, Prince of Songla University, Thailand. His specialization includes diagnostic radiology and advanced diagnostic body imaging. His scientific activities include clinical research and clinical trials on radiologist workload, artificial intelligence, and pulmonary tuberculosis. To introduce the ILO classification of chest radiographs of pneumoconiosis as basis and its use in detection of silicosis, we have Dr. Wiwatana.
Good evening, everybody. I feel honored to present to you the topic, an introduction to ILO classification of radiographs in pneumoconiosis and its use in detection of silicosis. My name is Dr. Wiwatana Taramkiat from Thailand. I am a radiologist, an ILOB reader, and I work in a pneumo project for a couple of years. The ILO classification of radiographs is an important tool in epidemiologic studies of pneumoconiosis to survey, communicate, compare, or monitor the prevalence of pneumoconiosis. It is not intended to define pathologic entities or to assess working capacity of the workers or to imply compensation. The purpose of ILO classification is to standardize and unify the way the readers describe and record the radiograph in 5 sections. Section number 1 is about technical quality. Section number 2 is about parenchymal abnormalities which are consistent with pneumoconiosis. Section number 3 is about pleural abnormalities which are consistent with pneumoconiosis. Section number 4 is about other findings which are unlikely to be pneumoconiosis. Section number 5 is about the comments from the readers. The details in each section are precisely defined to minimize inter-reader variation. Section 1. The quality of the image will be evaluated and graded into Grade 1 if it's perfect, Grade 2 if it's acceptable without any defect to impair classification, Grade 3 if it's acceptable with some defects but still adequate for classification, and unacceptable if there are defects that impair the classification. If the image is not grade 1, a comment should be made. Section 2 is about parenchymal abnormalities which are consistent with pneumoconiosis. Parenchymal abnormalities are categorized into small opacities if the diameters of the findings are less than 1 cm, and large opacity if they are larger than 1 cm. Small opacities will be classified into 6 categories according to the shape and size. For example, round opacities will be recorded as P if they are less than 1.5 mm, Q if they are between 1.5 to 3 mm, and R if they are larger than 3 mm. Irregular opacities will be recorded as S if they are less than 1.5 mm, T if they are between 1.5 to 3 mm, and U if they are larger than 3 mm. Round opacities mean their greatest diameter is less than 1.5 times smallest diameter. Record the symbols twice if they are the same. For example, record QQ if all small opacities are round and between 1.5 to 3 mm. If they are mixed, the first letter is the majority. For example, QT if the majority is Q and minority is T. The vertical distance from the apex to the base of each lung is divided into 3 zones, which are upper, middle, and lower lung zones. The affected zones will be marked. Profusion means concentration or abundance of the small opacities, which are graded into 4 scales by evaluating the lung markings of the affected zone. 0 means there is no small opacities. 1 means there are small opacities, but the lung markings in the affected area are clearly demonstrated. 2 means the small opacities are abundant, that the lung markings are partly obscured. 3 refers to that the small opacities are concentrated and the lung markings are completely obscured. Profusion extends to 12 subcategories. For example, 2/1 means when compare the subject film with the standard films, the profusion is less than 2/2 but more than 1/1. The large opacities will be recorded according to the summation of the largest dimension of each large opacity. A means the summation is not more than 5 cm. B refers to the summation is more than 5 but less than the area of right upper lung zone. C means the summation is larger than the right upper lung zone. Next to the parenchymal abnormalities are section number 3, pleural abnormalities, which are classified into plaques if they are circumscribed, and diffuse if they are not circumscribed and obliterate the costophrenic angle. Plaques and diffuse pleural thickening are further subcategorized according to the site, classification, extent, and width. The sites of pleural abnormalities will be recorded separately for the right and the left sides. They will be recorded as in profile if they appear on the lateral chest wall, and face on if appear on the anterior or posterior chest walls. For pleural plaques, 2 additional locations include diaphragm and other sites, for example on the mediastinal pleura, paravertebral or paracardiac. Extent is the total length of the profile combined with the face-on plaques or diffuse pleural thickening. Extent is graded into 1 if the involvement is up to 1/4 of the lateral chest wall, 2 if more than 1/4 but less than half of the lateral chest wall, and 3 if more than half of the lateral chest wall. The thickness of pleural plaques and diffuse pleural thickening will be measured for only those in profile. A minimum width of 3 mm is required for both pleural plaques and diffuse pleural thickening. A means that the thickness is not more than 5 mm, B if from 5 to 10 mm, and C if more than 10 mm. Section 4. Other symbols. These symbols include other diseases that may appear on the image or share common findings with pneumoconiosis. For example, Ca, which stands for cancer, is usually marked if there is a large opacity, or Tb, standing for tuberculosis, is usually marked if there are small opacities in the upper lung zone. Some symbols could be related with pneumoconiosis but not specific. For example, eggshell calcification of the lymph nodes or coalescence of small opacities could be found in silicosis, but they could be also found in other disease entities too. The correct use of ILO classification needs 4 components: the subject radiograph, the standard films, the guidelines, and the record form. The common manner to save time among radiologists is that the reader should characterize and estimate the severity of the findings in mind before choosing standard films to compare. For example, there are around small opacities with their sizes could be R or Q on this subject film, because the underlying lung markings are still visible, so the severity could be 2 or less. Then the standard films to compare could be RR or QQ with coefficient ranging from 2 to 3. After that, select out the closest standard film. If this subject film corresponds closely to 2/2 RR, then use that full category. If less, use 2/1 RR or 2/1 RQ. If more, use 2/3 RR or 2/3 RQ. NIOSH Reader Program is a program to train and test the readers, to ensure competency in radiographic reading, and to identify and pool qualified readers. The readers who pass the examination are called NIOSH Certified B readers, which need to be recertified every 5 years. There are 2 prototypes of pneumoconiosis. One is silicosis, and the other is asbestosis, which are opposite in terms of shape and location of small opacities. Silicosis appears as small, round opacities at the upper parts of the lung, while asbestosis appears as small, irregular opacities at the lung bases. It is well known among physiologists that the lymphatic clearance in the upper lung zones are less than in the lower lung zones. It is believed that the presence of tuberculosis and silicosis in the upper parts of the lungs is because that the elimination or clearance of these diseases are less effective in the upper lung zones. Dust in the inhaled air can be removed by 2 ways: by the mucociliary system if they are large, and by macrophages if they are small. Small dusts that can enter deep into the level of alveoli can be removed by macrophages and accumulated around the respiratory bronchioles. The accumulated silica dust around the respiratory bronchioles are called silicotic nodules, which appear on radiographs or CT as small round opacities. On CT, especially high-resolution CT, early silicotic nodules will appear around the airway, very well known among radiologists as sentilobular nodules. At this stage, these nodules are not visible on chest radiographs. It brings to the idea of using high-resolution CT as a screening tool for early silicosis, because CT is far more sensitive than chest radiographs. When time goes by, silicotic nodules will become larger, to be P, Q, or R. Not only the size, but also distribution of these nodules that changes, because direction of lymphatic clearance is towards the hilum if the ducts are in the medial 2/3 of the lung, and towards the costa pleural if the ducts are in peripheral 1/3. Chronic accumulation of the ducts also appears at these 2 structures too. This distribution is known as polylymphatic distribution. Progressive massive fibrosis of PMF is an accumulation of silicotic nodules to form a mass-like lesion. These CTs in a 5-year follow-up period nicely demonstrate how PMFs in both lungs were formed. The PMF tends to move to the hilum over time. Once PMF is formed, it usually makes surrounding lung become emphysematous. PMFs will be recorded as large opacities in the ILO classification. On CT, PMF can be calcified and also cavitated, simulating lung cancer or tuberculosis. However, presence of surrounding silicotic nodules and emphysematous lung peripheral to PMF and careful review of prior serial CTs could ensure the diagnosis and obviate the need of biopsy. The chest radiograph of this patient shows that there are numerous nodules in both lungs, mainly the upper lobes, where there are also calcified large opacities. Observe that there are calcified hollow and mediastinal lymph nodes, which are called eggshell calcifications, and better demonstrated on CT. Eggshell calcifications are quite common in silicosis, but they are not pathognomonic because they could be found in other granulomatous diseases such as tuberculosis. Silicosis is usually clinical radiological diagnosis. The diagnosis can be made in a patient who has a strong history of exposure, and there are parenchymoid abnormalities consistent with silicosis, which are small, round opacity in the upper lung zones, with or without large opacities or eggshell calcifications. These parenchymoid abnormalities are much more clearly demonstrated on high-resolution CT. Pleural abnormalities are not common and not findings suggestive of silicosis. Nowadays, pathologic diagnosis is rarely required in most of the cases. ILO classification guidelines are available online. The latest edition is 2011, which is the edition 2000 plus new chapter 6, describing the correct use with digital images. The upcoming edition is 2022 with digital standard films. Thank you very much for your attention.
Thank you, Dr. Wiwatana. That was a very informative discussion on the ILO classification. Just imagine that we, across all nations and countries, can harmonize the reading of silicosis as well as we are able to differentiate it from other occupational lung diseases. For those who just tuned in or logged in our webinar, our open forum, in our open forum, we will get your questions and comments. So please type in the chat box or in the Google form provided in the Zoom. Dr. Somkiat Siri Rutanapruk is a senior advisor on occupational and environmental health under the Department of Disease Control, Ministry of Public Health, Thailand. He was the director of the Bureau of Occupational and Environmental Diseases, Ministry of Public Health. He received his master's and PhD degrees in occupational health from the University of Birmingham, United Kingdom. He has extensive experience in occupational disease surveillance, prevention of occupational respiratory diseases, and the development of occupational health service system. To talk on silicosis surveillance and prevention in Thailand, we do not only have an academic, but a technocrat that has developed the occupational health service system in Thailand. Let us all welcome Dr. Somkiat.
Thank you very much, Madam Chairperson. First of all, I would like to thank the organizer for inviting me to join the meeting today. Today, I would like to talk about the silicosis situation and surveillance and preventive measure program in our country. Silicosis is one of the most important optional diseases in Thailand. The first reported case was found in Wu family in 1954. After that, we found several cases in mines and in other manufacturing, such as in stone cutting and ceramic industry. Silicosis surveillance program was set up by the Division of Occupational Health in 1981, and it is the first disease selected to be one for elimination at the national level. We found several cases of silicosis in several types of industry. For example, the highest number of parents was found in sandpaper. So the second one is found in mortar making and other industry. Recently, for the last 5 years, the average number of silicosis was reported around 100 cases a year. The highest number, about 270 in the year 2018. The number of cases was found distributed throughout the country, especially in the province where high number of enterprises. For example, we found in the northeastern part of Thailand or in the southern part of Thailand. Right now, there are totally 4,700 enterprises who dealing with silica, and at least 80,000 workers were exposed to silica in their workplace. For example, in stone cutting, ceramic manufacturing. According to the mine in our country, most of the mines in Thailand are stone mines for construction and for cement production. The rest are in coal, potash, and salt rock. Very few mines are in the mineral mine. The Ministry of Public Health has been set up the silicosis surveillance and prevention program by the Division of Optional and Metal Diseases. The activity of the surveillance and prevention program include policy and legislation, development of optional health services, improvement of diagnosis of the disease among medical doctors. At least 3 government organizations dealing with optional health and safety in our country. Firstly, the Ministry of Industry has the duty on promotion and management of manufacturing sector. The Ministry of Industry also has the duty on control of import, use, and storage of toxic chemical and control of machine safety. The Ministry of Labor has responsible for enforcement of the optional health and safety standard and regulation. They set up the Dutch level. Lastly, the Ministry of Public Health has a duty on provision of optional health services in all sectors throughout the country. We can say that to control at source belong to the Ministry of Industry and Ministry of Labor. Recently, the Ministry of Public Health under the Department of Disease Control has enacted the new regulation we call the control of optional diseases and environmental diseases in 2019. The regulation focused on development and set up the standard optional environmental medicine services and surveillance of optional environmental diseases. Now I want to talk about the national program for elimination of silicosis in our country. The program following the ILO and WHO global program for the elimination of silicosis. The program in our country was set up in 2001. At that time, we set up the goal to reduce new cases to 0 within 10 years. The activity of the program involved the cooperation of all relevant organizations at all levels, such as to cooperate with the international level from the WHO, ILO, and ICOH, and also development of the cooperation between national agencies from different ministries. And we try to encourage the involvement of the organization until the enterprise level. At that time, we set up the program indicator. We proposed that within the first 5 years, we have to cover at least 25% of high-risk workplaces and try to control at least 50% of workplace to have the dust level within normal limit, and try to encourage the worker to use the PPE. And lastly, we try to detect and treat the worker with TB. After the first 2 years, after implementing of the program, we found that the coverage of workplace was approximately 45%. At that time, we focused only on the quarry and stone grinding factories and cover 58% of workers under the surveillance. Unfortunately, very few enterprises provide and encourage workers to use PPE. For the first few years, we got the funding to allocate directly to the province and to the hospital to perform medical surveillance. But after that, the Thai government changed the policy for the universal health coverage and set up the social health security office. At that time, the budget changed directly. We cannot allocate the money directly to the province. So the number of the workers and enterprise under the surveillance program decreased and decreases. And right now, only the hospital that interested to run the medical service or medical surveillance program, they got the budget from the workmen compensation fund, or they can get the money from directly from the enterprises. And this the data show the result of medical surveillance in some workplaces. For example, in the year 2020 or 2021, only 1,000 or 2,000 workers are under surveillance. And we also found at least 140 or 190 cases of silicosis. Another activity was to develop the optional health service. We set up at least 5 excellence centers for optional respiratory disease to support other general or regional hospitals to read and to share and to confirm diagnosis of cases of silicosis, and can get the consultant for the other hospital in the area. Actually, in our country, almost regional and general hospital has their own optional medicine section that they can perform medical surveillance in high-risk workplaces. And we also develop the basic optional health service in primary healthcare unit that I'll talk to you later. We also set up the program to improve diagnosis of silicosis by training for chest X-ray reading according to IO classification that Dr. Vivatana told you already. And we also developed the Pneumo project. This project is quite similar to the NIOSH Leader program we developed by our academy partner from Japan, from Professor Fumi and Professor Kusaka, and other country in Asian country and another country to develop the animal project. This figure shows the activity of investigation of cases in one stone guiding in community. After we got the reported case from the community, our team from the Department of Disease Control went to the scene and to perform dust measurement and detect cases of silicosis in the workplace. From this example, we could identify at least 12 cases, and all of them work as a stonemason in this home making or like a small enterprises in the community. And we also encourage the primary care unit in the sub-district level to be as the first gate to take care of the worker in their own, especially for the informal workers. At least the health officer at the primary care unit can interview and can perform some workplace survey, and they can get some information And if they need the medical surveillance, they can consult with the community hospital or the general hospital to perform higher medical examination. And we also developed the program to identify the suitable control measure for dust measurement, for dust control. And we work this together with the university to try to develop. And this is practical and very cheap for the worker in informal worker to use this one, especially for the stone cover. We still have some obstacle and problem to run the program of surveillance and prevention of silicosis. For example, many employer and employee are not aware of the disease, and sometimes they cannot find a suitable control measure. Especially, most of our control measures are very expensive for them to invest. And right now, we can say that health officers have no authority to enter to the workplace because most of the authority belong to the Ministry of Industry and the Ministry of Industry and Ministry of Labor. And every day we try to encourage the health officer to support the local workers, especially for the informal worker. Finally, we can say that silicosis is the most important optional disease in our country. The number of high-risk workplace and workers are still very high. And lack of diagnosis by physician is one of the most important problems. We need to encourage medical doctors and to support them to can go to the workplace and perform medical surveillance. But important thing that we need to find a solution for the control measure at source. And finally, continuous implementation of the national program for elimination of the silicosis is very essential. And right now we have to admit that we cannot control or eliminate the case within 10 years. We have to extend to another 20 years. And thank you very much for your attention.
Thank you, Dr. Somkiat. Indeed, as shared and shown by Dr. Somkiat, silicosis prevention and control requires the strengthening of national capabilities and establishment of national programs, including robust surveillance system and control strategies, such as the use of personal protective equipment. Dr. Somkiat has also shown to us the best practices for occupational health in Thailand, especially the integration of occupational health services in community clinics and hospitals. And this is very important because mining industries and related industries are not really located in urban areas or the cities, but rather in provincial areas. Hopefully, other countries can follow through such system as was presented by Dr. Somkiat. And now, from the other side of the continent, South Africa, we may be wondering, what are some efforts on silicosis surveillance in this part of the globe? Professor Rodney Ehrlich is a specialist in occupational medicine and public health, and currently emeritus professor and senior research scholar of the School of Public Health and Family Medicine at the University of from the University of his School of Public Health and Family Medicine, University of Cape Town, South Africa. His career has encompassed clinical practice, teaching, research, policy, support, and advocacy. He is the past co-editor-in-chief of the American Journal of Industrial Medicine. His current research interests include the health and compensation of former miners in Southern Africa and the biological, clinical, and epidemiologic aspects of silicosis and related pulmonary tuberculosis. An academic, a journal editor, and trailblazing in research, policy, and advocacy for the South African miners, and now to talk on surveillance of silicosis and tuberculosis in Southern African mining populations. A warm of applause to Dr. Rodney Ehrlich.
Thank you. My picture's not coming up, but can you hear my voice?
Yes.
Well, good afternoon, evening, morning, everybody. Thanks, Jinky and Mukhtar, for inviting me to participate in this MinOSH meeting. I particularly value the opportunity to make contact with our Asian colleagues, because I think the problems I'm going to talk about today are particularly relevant to a number of countries in Asia. Next slide, please. I'm going to take the opportunity actually to reflect on medical surveillance and occupational health, to make some general comments, and also to focus on some of the interesting aspects, controversial aspects of screening and surveillance in miners as drawn from our experience in South Africa. So I think the term medical surveillance in occupational health is unfortunate because it really conflates two quite separate activities. One is screening, which is screening of individuals for medical or occupational intervention for the value of the individual, from surveillance of disease, which is really a national or governmental or institutional process for collecting cases directed at preventing disease and allocating resources for services and prevention. Now, this distinction is well known in the public health word for tuberculosis because it is actively treatable. Active disease for tuberculosis is sought, or in some cases, TB infection for TB preventive therapy. Surveillance of TB cases for monitoring, resource allocation, and primary prevention, which in this case would be dust control, are well understood. It's less clear when we think about silicosis. There's no accepted medical treatment following screening, so that the intervention is focused on change of employment status and social security, and these are almost universally problematic. So the question has to arise: who benefits from screening workers, particularly for early silicosis? Surveillance obviously implies, surveillance does apply to silicosis, but the time scale is long. When you're picking up cases, you're looking at events that may have taken place 10, 15, even 30 years previously. What we've seen in the previous presentation actually was an important example of the fact that screening is not simply about clinical tests. The literature sometimes makes it seem so. What we need in addition are systems or program approaches to screening. For this context is all important. Next slide, please. South Africa's had a gold mining industry for 130 years now in decline, and has, although cyclical, had very high instances of silicosis and tuberculosis, and in recent years, HIV. Silicosis, as we know, everybody knows, a long latency disease, but what is less well appreciated is that even after treatment, and particularly in miners that we found, there is a lifelong experience of chronic post-TB respiratory mobility, recurrence of active TB, and increased mortality. So in a sense, they are both long latency conditions. The access to services is very starkly demonstrated in South Africa, where active miners have access to the medical services in larger mining companies who have developed huge, expensive, and continuous screening programs, particularly for tuberculosis, and in recent years also for silicosis. This comes to an end when miners leave the mining industry. The number of active miners, which was about 500,000 underground in gold mining in the late 1980s, is now down to about 90,000. The number of ex-miners now dwarfs the number of active miners. We estimate that 1.2 million men, almost all men, but women in recent years, passed to the South African gold mines between 1975 and 2012. These came from 5 different countries, from South Africa increasingly, but also from Mozambique, Lesotho, Botswana, and Eswatini. These ex-miners are reliant on under-resourced state medical care, which I believe will resemble the conditions pertaining in the rural areas of countries in Asia, well represented at this meeting: India, Thailand, China, and so on. This group is aging, so with the accumulation of comorbidities, In recent times, there's been an effort to reach these ex-miners with the emphasis on compensation eligibility, partly due to litigation via a class action suit which provided a settlement of $330 million to examine, find, examine, and where eligible, compensate ex-gold miners. Next slide, please. This is the map of South Africa and the 5 surrounding countries. It's very detailed. I believe the presentation will be put up for scrutiny, and I'm going to move on. Next slide, please. So zooming out a bit, when we're thinking about the tools that are available for screening and surveillance, we've heard there's been a strong emphasis at the meeting thus far on radiology. I think one needs to think about what would apply everywhere. And what I suggest is that the core is education of the people being screened, the people doing the screening, whether it's employers or medical providers or nurses in whatever area, plus the ability, following education, for those who want to be screened to seek such screening, which I call passive screening as opposed to active or mandatory screening, plus some sort of health service with an occupational health component. When we come to the specific diseases, I'm going to just talk about a few. For silicosis, we use risk indicators to identify high-risk groups for screening. I just want to say something briefly about length of service. Radiology is clearly central. What is perhaps peculiar to South Africa with regard to surveillance is autopsy. And I want to present this because it is unique. And I want to say something about biomarkers. The screening for tuberculosis and surveillance, as I say, are well-established public health programs, and many of the principles are exactly the same when screening and doing surveillance in the mining sector. But I just want to talk about the relationship between silicosis and tuberculosis as a risk predictor relationship. Radiology, including computer-aided detection, on which I've been doing, and my colleagues have been doing some research, and autopsy. As I say, the other modalities are well known. I'm not going to talk about lung function testing, although this is used in screening. It is non-specific, a non-specific measure of impairment with regard to specific disease. Next slide, please. We all know that the longer the exposure, the greater the risk of silicosis. So when you do a study and you want to find the best predictor of the data that you have, years of service is often used as a proxy for cumulative dust exposure, which is usually not available. However, the point I want to make here is that an epidemiologic study showing a high relative risk for silicosis of a particular risk indicator or biomarker would apply here as well, does not mean that that risk indicator or marker is an accurate prediction of silicosis in individuals. I'll come back to that. Next slide, please. We recently did a systematic review of the relationship between silicosis, silica exposure, and tuberculosis. And this is well known, it's been known for 100 years, that somehow there has been controversy, certainly in South Africa, about the exact relationship. What we found is, these are more modern studies, wherever you looked, the same pattern emerges, that where there's silicosis, there's an increased risk of tuberculosis. And the more severe the silicosis, that's marked by different colors on these histograms from these studies, the greater the risk of silicosis. The pooled relative risk we found is 4. Now, apart from HIV, if you look at all the risk factors for, and possibly malnutrition, you look at all the risk factors for tuberculosis and public health, this is number 2. When we looked at silica exposed group studies where they were able to control for silicosis, we found a smaller relative risk of 2, but with lesser confidence because of the problem of measuring exposure. And that has been published. So silicosis is an important, the screening of silicotics for tuberculosis, I think, is a necessary step in screening. Screening of those who have been exposed to silica would be advisable, but depends on context. Next, please. Radiology. So I'm just going to really talk about plain film radiology. The combination of silicosis, PMF, this distortion, of old tuberculosis with every possible distortion of the lung field that you can think of virtually, plus or combined disease makes plain film radiology difficult in a mining population. At the one end, it is clear that the silicosis is present and no TB. At the other end, active TB or old TB, no silicosis. But frequently, the problem facing the radiologist or reader is to distinguish silicosis from tuberculosis, and if tuberculosis, whether old or active, from combined disease. The exclusion of active TB is particularly difficult. Now, radiologists tell us they do not make a diagnosis of active TB, but they suggest that active TB is possible and should be excluded clinically in a radiograph that faces them. This problem is greatly exaggerated in this particular setting. And the practical implications are important. On the one hand, we have underdiagnosis of active TB because it's difficult to identify active TB on the X-ray. So unless you're screening everybody with, for example, gene X or sputum or culture, you're not going to pick up a lot of these cases purely radiologically. But paradoxically, there's also overdiagnosis. We've recently done a case series in Lesotho and have found cases that have been treated up to 5 times for tuberculosis, where only in 1 case was there bacteriological confirmation. And this is because medical practitioners faced with X-rays like this, faced with symptoms which are non-specific, are treating on spec presumption. So that is overtreatment. ILO training in this context is obviously necessary, but is not sufficient. One needs to be familiar with this very difficult series of combined or competing diagnoses. Next slide, please. We've recently done work on computer-aided detection for silicosis. There's now a large literature and a number of commercial products for the detection of tuberculosis. It's been recommended conditionally by the WHO. The CAD for silicosis is still in its the relatively early days when it comes to clinical application, although there's been a lot of laboratory work. There are actually very few publications. This is a study we did comparing one software system against 2 readers for silicosis. So the readers here, as they have to be, are the gold standard. And I want to introduce, for those not familiar, the receiver operating curve. When you have a predictor which is numeric on a scale of 0 to 100, you can use these curves which gives you a family of thresholds which generates the sensitivity and specificity of the instrument for the reference standard or gold standard. So what you, in the graph on the right, what you want to do, the diagonal is no difference from chance, is get the curves of agreement up into the left-hand corner where the actual corner would be perfect sensitivity and perfect specificity. That's unlikely to be achieved. In other words, the more concave the curves, the greater the agreement. In this particular case, the system did well against both readers, reaching sensitivity of 90%, well, certainly against one of the readers, or if you fix the sensitivity at 90%, good specificity. So in a sense, the CAD for silicosis with this particular software system is ready to be applied in operational and implementation settings where I think it needs to be monitored and the results published to see whether they produce or meet the objectives of the screening system. Next, please. South Africa has a unique autopsy system. How many minutes have I got left, Jinky?
Wait, yeah, please proceed.
Sorry, yeah, okay. The autopsy system is unique in South Africa. It's a legal requirement under the compensation system, an archive of 110,000 autopsies, mostly gold miners, has been collected. Migrant ex-miners underrepresented. The large majority that come to autopsy are those still in service, where consent can be obtained, and the number is shrinking. However, for surveillance purposes, this autopsy database has been invaluable. Next slide, please. This provides a year-by-year surveillance picture of the proportion of autopsies coming to, a proportion of cases coming to autopsy, so the proportion of disease, in this case silicosis, pulmonary tuberculosis, coming to autopsy across a period of over 40 years. And what it's able to tell us that from a proportion of silicosis in the early years of 3%, that a new or renewed epidemic of silicosis has occurred in the industry, and reaching as much as 23% in recent years. Next slide, please. Autopsies also give us an indication of the limitations of clinical diagnosis. In one study, which was done in the 1990s, the proportion of silicosis autopsy not detected on plain X-ray was about almost 60% where any silicosis was present, and almost 40% even where moderate or marked silicosis was present at autopsy. So silicosis is substantially a subradiological disease in minors. Similarly, for tuberculosis, a study between 1996 and 2000 of over 1,500 cases found that of cases of tuberculosis diagnosed at autopsy, of which 90% were extensive, 64% had not been diagnosed as TB in life. Next slide, please. The last tool I want to talk about is biomarkers. Many have been proposed or researched. There are biomarkers of exposure, biomarkers of effect, and biomarkers of susceptibility, and I refer you to my colleague Mary Gulamian's in-depth review of 2006. However, to my knowledge, none of these biomarkers are in widespread or regular use. And we must ask the question why. It's also important to note, as I mentioned earlier, that we need to make a distinction between group discrimination, that is to be able to distinguish average silicosis present versus average not, from accurate identification of specific individuals with silicosis. So really, I should perhaps end on the question of ethics. Ethical questions abound when we do silicosis, when we screen, less so for surveillance. When you approach someone for active screening or even mandatory screening, the ethical burden on whoever's doing the approaching, whether it's the industry or the occupational health service or the national, whatever national jurisdiction, there's a greater ethical burden to do no harm than when an individual seeks care as a patient. Secondly, one has to factor in potential loss of livelihood as a potential disaster for the individual and his family. And when we propose early screening for silicosis, we have to ask ourselves, what will be the consequence of finding early silicosis or even subradiological silicosis? What will be the outcome for the individual, and what will be the outcome for the population at risk? And really what it comes to is the question of the linkage. How is the screening program linked to surveillance? In other words, all the screening that we're doing for tuberculosis clearly is medical treatment. What is the outcome with regard to reduction of dust exposure and silicosis and disease in the future to which this information is put? I think I'm going to end on that note. I have a couple of other slides which will be up on the, will be put up on the website, I believe, but those was more or less by the way of summarizing the messages I wanted to get across. Thank you.
Thank you, Dr. Rodney Ehrlich. Okay, ILO training, as stated by Dr. Rodney, is necessary but not sufficient. And thank you, Dr. Rodney, for showing us the other methods that could make it sufficient. And indeed, there are several ethical questions that abound in the surveillance of silicosis and other occupational lung diseases that we also have to address. Dr. Prahlad K. Sishodia is a medical graduate of New Delhi, India, and holds a postgraduate degree in occupational hygiene from the University of Newcastle upon Tyne in the United Kingdom. He was the director of the National Institute of Miners' Health, and he was also the president of the Indian Association of Occupational Health in 2000. After superannuation till January 2022, he was a full-time consultant of the Occupational Health, Building and Other Construction Workers Welfare Board, state government of Rajasthan, mainly engaged in health screening for silicosis. He was also instrumental in framing the Rajasthan policy on pneumoconiosis. As one of the framers of the pneumoconiosis program in India, we are privileged to hear from Dr. Sishodia on experiences in India.
Can you hear me now?
Yes.
Good morning, good afternoon, and good evening to the people all over the world attending this MinOSH webinar. I'm really thankful to the MinOSH and the ICOH for giving me the opportunity of sharing my experiences. Previous speakers have talked about how to conduct surveillance, what kind of control measures are required, and what kind of biomarkers have been used. What I'm going to talk about is how to provide relief to the people who are suffering from silicosis, who are having a debilitating disease which is invariably fatal and which causes a lot of suffering to the people. I'll be talking about the state of Rajasthan, which has devised a policy on providing relief and rehabilitation to the silicosis people. This is not a compensation scheme. This is just to provide relief to the people who are suffering from the disease. Rajasthan is famous for its monuments and the forts, and it's one of the western states of India, bordering Pakistan, which is rich in minerals, especially the metal minerals. And the state has a 0.5% of geographic area under mining. It has highest number of mining leases, which totals around 33,122. And mining and mineral processing industry provides direct or indirect employment to 3 million persons. And building other construction industry also employs around 3.5 million people who are at the risk of exposure to silica dust and potentially the risk of silicosis. It's nice to know how the whole story started of developing this particular program. Earlier, sporadically, the cases of silicosis was reported from Rajasthan, but there are no organized program to conduct screening or surveillance. An NGO, while implementing the Family Livelihood Resource Center program, observed that the people who had history of employment in stone mines had very high prevalence of debilitating respiratory diseases, which directly affected their family livelihood. And they suspected that people who are suffering from the respiratory diseases may be suffering from silicosis. They approached National Institute of Miners Health, Nagpur, in February 2011 for the help. The NGO conducted medical examination of 101 persons suffering from respiratory symptoms, which had history of work in stone mines. And the medical examination included chest X-ray, history of work, respiratory symptoms, treatment for tuberculosis, sputum and routine blood examination, pulmonary function test. And the records for medical exam were submitted to the National Institute of Miners Health for evaluation for silicosis. This is the typical example of a sandstone mine, which is totally manual and very little mechanization occurs. A block of stone is split into various sizes and then used for mainly as a building material or for the carving, stone carving. Now, while evaluating these records of 101 persons, of which 93 were suitable for evaluation, we found that 78.5% of these people were actually suffering from silicosis. And of these, 16 were having associated large opacities suggestive of PMF, and 17 others had associated radiological opacities suggestive of tuberculosis. Further, when we classified these into their age groups and the years of work, we found that the prevalence of silicotic opacities increased with the number of years the person had worked, and almost everyone who had worked for more than 30 years had silicosis. Based on this report, which was submitted to the government and various agencies which are involved in detection of silicosis or were responsible for silicosis, the government identified 19 mining districts of the 33 districts of the states which were considered silicosis prone. Another area which was which came to the light while doing these studies was that people who are working in the stone carving industries, which was not recognized earlier as a case of silicosis prone, we found that people who had worked in the stone carving industry had a very high prevalence of silicosis, which occurred at the younger age. Though this particular work is carried out almost everywhere in this particular state, but some of the districts had a very high prevalence of stone carving industry. This is a typical workshop which you will find in a stone carving industry. People are engaged in a small place where majority of the operations are carried out on sandstone. This is a cutting operation which is going on and which is leading to very high exposure of silica dust. Normally sandstone in this particular area contains 30 to 70% silica, crystalline silica in the dust. This is grinding operation where the stone is ground to give it a shape. And while surveying one of the districts, we found that out of 1,198 persons who reported for health screening, we found 587 or 49% of the cases, people who came, they were having evidence of silicosis. 46 of these people also had associated large opacities of PMF, and 225 people had fibrosis associated with silicosis and tuberculosis. Based on these early reports, a silicosis screening program was started in all the districts of the state, which included lung function test and the screening for the chest X-ray and the medical examination. And a scheme was also started for providing, because it came to the notice of the state government that many of these people could not afford the treatment. So the state started a scheme for providing them relief to the point of 300,000 rupees to any person who was suffering from silicosis, and if the person died, 200,000 rupees more to his family for rehabilitation. It was also observed that silicosis was not restricted to the mining industry and the stone carving industry or building and other construction industry. It was also presumed that many of the people who were in other industry were also found to be suffering from silicosis. So the state government decided that there was a need to have a comprehensive policy on silicosis detection, prevention, control, and rehabilitation, which was adopted by the government as a primary prevention program for the silicosis in 2019. This is the policy which was the official document of the state government of Rajasthan. The mission of this policy is, the mission of the pneumoconiosis policy of Rajasthan will be prevention and control of pneumoconiosis as an occupational disease with the ultimate aim of elimination and to provide relief and rehabilitation to the affected persons. Mind you, this is not a compensation scheme. This is basically for providing relief and rehabilitation to the people who are affected with silicosis. Now, what the goals of this particular policies were: that establishing an efficient system for detection, certification, and treatment of pneumoconiosis cases, which include silicosis, upgrading screening and treatment facilities in areas with high prevalence of pneumoconiosis, establishing a system for providing relief and rehabilitation to the affected persons, identification of pneumoconiosis prone industries, mines, factories, and other establishments, implementation and enforcement of measures for prevention and control, organizing awareness and training program for all stakeholders, and implementing statewide comprehensive program for detection, prevention, control, and elimination of pneumoconiosis in general. Because initially we thought silicosis was silicosis was a prominent occupational disease, but while thinking the long term, we decided that this policy should encompass all the pneumoconiosis group of diseases. That's why it was called the pneumoconiosis policy. The basic features of this particular policy are that there will be a rehabilitative assistance of 300,000 rupees, which is equivalent to around $4,000, a one-time assistance. Assistance on death of the person to the family to the tune of 200,000, which is around equivalent to $2,670, and rehabilitation pension to the person who is suffering from silicosis of 1,500 rupees per month, or person equivalent to the person with special disability. Pension to the widow, wife, or is his entitled beneficiary from the other state government's welfare scheme. Funeral assistance of 10,000 rupees and free treatment and medicines for the victims. How the system works is that there's an online registration system of the person. That means any person who is desired to be screened for silicosis, he registers himself on an online registration system. His initial screening is carried out by the nearby community health center, where he's referred for initial screening, and the silicosis for the silicosis based mainly on the X-ray. And once he is suspected to be suffering from silicosis, then he's referred to the district pneumoconiosis board. Every district in Rajasthan has a pneumoconiosis board, which consists of a radiologist, a chest physician, and a general physician, which evaluates the person in detail and certifies the case of silicosis. If he is certified, if the person is certified with silicosis, then his basic information, like which place he belongs to, whether he's registered or not registered, that information is validated by the district authorities. And once the information is validated, he is referred back to the system for disbursement of the relief through a direct bank transfer system. And payment is made from the centralized pneumoconiosis fund, which the government has created from various contribution by Building and Other Construction Workers Welfare Board, Mines Board, and the state government. And the whole process is online with minimum human interference, because we had observed over the years that wherever there was a human interference, there were irregularities. There were also problems in delay in paying the relief to the people. This system has been now very much in implementation. And what we have implemented in this particular policy is there's an online registration portal for screening system. Now, there's a one-time financial assistance, as I already said. And in addition to everything else, there's a quarterly monitoring and review committee under the chairmanship of the Chief Secretary of Rajasthan. Chief Secretary is the highest bureaucrat, and he is directly reported to the Chief Minister of the state. And there's a district level task force group for policy implementation. What are the features of policy implementation? They are monitored at the district level by this task force under the district collector. Now, what is the status of implementation of this relief scheme as on 31st May 2020? We have online system, so anybody can check in, and even today's figures are also available. But I have taken the figure which is 31st May 2022. The system has registered 181,687 persons on the system for screening. District pneumoconiosis boards have certified 23,436 cases of silicosis since the start of online system, which includes 6,876 cases of death due to silicosis. Additionally, there are 17,687 cases which were certified prior to the online system till May 2019, including 1,857 cases of death due to silicosis. 30,293 silicosis affected persons have been disbursed relief, and 31,121 silicosis victims have been registered for disability pension now. More than 5,500 million rupees have been paid as relief to the silicosis victims. This is equivalent to around $73.3 million. And there's a project monitoring unit for prevention and research on silicosis have been set up recently with the allocation of 50 million rupees as the initial fund, which is equivalent to $670,000 for starting prevention research aspects. What are the lessons which we learned from this particular policy implementation? Is the prevalence of silicosis much higher than what is generally believed, and large number of cases go undetected. Imagine if more than 42,000 cases of silicosis have been detected just in Rajasthan, then there are many other states in the country which do not have a program for silicosis detection. Most cases of silicosis are undiagnosed or misdiagnosed as pulmonary tuberculosis. Participation of all stakeholders, including workers, NGOs, union, media, and state government is important for formulation and implementation of policy. Why I would like to emphasize this particular point is the strength of this policy has been that this policy came from the field. Invariably, what happens in the government is the government makes a policy and puts it on the field for implementation. This policy was devised basically on the experience of what we felt at the ground level, and then the state government adopted it. So most of the relief and rehabilitation came from the ground level, starting from the NGO, from the union, from the workers, and the state government officials. And then it was framed into a policy. So because there's already system existing for implementation, the implementation becomes easy. The most important thing which we observe, quick monetary relief to the silicosis victim ensures participation by the affected person and successful implementation policy. See, everybody wants that once he is diagnosed with silicosis, he must be provided relief by the government or whatever agency is supposed to do it. So if you have a quick monetary relief or any system of compensating him, which invariably what happens is you have a person is diagnosed, which takes years to get compensation or to get relief. If you have a quick system of implementation of giving him relief, then the implementation becomes easier and the people start participating in your program. And the policy implementation should be from cess on the industry and must be independent or partially dependent on the government budgetary allocation. Because what happens if the total policy is funded from the budgetary allocation of the government, it is susceptible to the change in the government, it is susceptible to the political system. And if the government loses importance of this particular policy implementation, then the things become difficult to implement. Once it is coming through a cess or the tax on this industry, then the funding is always available to you for implementation of policy. What are the lessons from this particular policy which we would like to share with this audience? Is the ease of registration of detection, certificate, and disbursements relief for silicosis victims are most important aspect of the policy implementation. The system should be such that anyone can register it and anyone can be certified, and it should be a smooth working system. Training of medical doctors is important for uniform standard of detection and certification of silicosis. What do we mean to say? If we have 33 boards which are diagnosing silicosis, there must be uniform standard for silicosis detection, which everybody follows. An online portal for registration, certification, disbursement of relief is an effective way of implementing policy. As soon as you start having human interface between the people, there's always a system developing inertia because people become dependent on people. What we want to say is, if you have online portal system, if you online registration, online certification, online, it becomes easier to implement the system. And media plays an important role in creating awareness among the public and other stakeholders. Media has a very, very important role. Sometimes we blame media, sometimes we say they have a negative role, but it was our experience. If you take the media along with you, then it has a very important role in creating awareness. And monitoring at the highest level of government is extremely important for effective and efficient implementation. See, our experience has been that if the monitoring of any policy, or particularly this policy, is at the highest level of the government, that means the chief secretary or the chief minister level, then of course the policy becomes much more effective in implementation. I'm thankful to the Building and Other Construction Workers Welfare Board, Labor Department, and other departments of the government of Rajasthan. And thank you very much. This is a typical silicotic patient with the oxygen support. And we have been able to bring smile on faces of some of these people by providing relief and rehabilitation. Thank you very much. Thanks for listening to me.
Thank you, Dr. Prahlad. As shown by Dr. Prahlad, policies must be established for occupational lung diseases, including silicosis and pneumoconiosis, since policies, as he has shown, serve as overarching value basis for programs, and set in motion projects aimed at silicosis and pneumoconiosis control. Wow, what an informative and exhaustive webinar on silicosis detection and current updates we have had, all packed in 2 hours in a nutshell. We in MinOSH ICO are indeed very honored and privileged to have been graced by our esteemed speakers. Thank you so much, our speakers, for sharing the core of your knowledge and experience on this specialized topic. For our audience, which would not have been possible without your dedication to twin your experience with advocacy. And this, our webinar, is one avenue for such. Now, the floor is open for the open forum to be moderated by Professor Mukhtar and Dr. Prahlad. Mukhtaruddin Mansoor is currently the Secretary of MinOSH. He is the Director of the Regional Center for Food and Nutrition of the Southeast Asian Ministry of Education, or the SIMIO REFCON. He is a Professor of Community Medicine at the Universitas Indonesia. He is a medical doctor, which he earned from Indonesia, and PhD in Health and Community Care from Leeds, United Kingdom. Again, please type in your questions and or comments. Dr. Mukhtar, Dr. Prahlad.
Well, thank you very much, Jinky, for nice introduction for the open forum. We have got a lot of new knowledge from the 5 outstanding speakers, and the participants are anxious to ask a lot of questions that we have got by far. For not how to do, please. The first question is for everyone. Come from. Okay, well. From Dr. Mihir, India, for Dr. Fumi, and also for everyone. The first is, what was the reason for the sudden decline in cases of silicosis in Japan post 1985? This is for Prof. Fumi, and the second question is for everyone, I think, from David Rees. Does anyone know of publication that show that high resolution CT is superior to plain radiology in distinguishing silicosis from active and inactive tuberculosis in cases where both conditions are suspected? He gives the example. Is CT useful to demonstrate silicosis in cases of extensive inactive tuberculosis, which may obscure or mimic silicosis on plain radiology? Well, Prof. Fumi, please, your state. Hello, Prof. Fumi.
Hello?
Yeah. Please answer the question of Dr. Mihir.
Oh, actually, sorry, I actually, wasn't following your, questions. Could you say that again?
I'll repeat. What was the reason for the sudden decline in cases of silicosis in Japan post 1985?
Thank you very much. Actually, in Japan, pneumoconiosis law was introduced in 1960, and we started, the medical screening and surveillance in 1960. But that was not really covered the whole population, and we actually revised the system. We revised the classification system in 1982, and actually that seems to be the kind of a, the kickstart for the, surveillance and the screening system. And, we believe that, this system actually, reinforce the prevention in, especially in the big companies, and it's spread out all Japan. So, probably, this is the main reason for the reduction of the new cases in Japan.
Well, thank you very much, Prof. Umi. For everyone from the Fitris, may I repeat the question? Does anyone know of publication that show that higher resolution CT is superior to plain radiology in distinguishing silicosis from active and inactive tuberculosis in cases where both conditions are suspected? Prof. Umi, please continue to answer and then go to other speakers.
Probably, Professor Erich will, tell you a little bit more about that. But I will just tell you that, in the HRCT finding, I think that, radiology literature in, there's, the paper from, South Korea that the Dr. Im reported about the, tree in bud region in the active tuberculosis, which can be, seen in an active tuberculosis, in especially in HRCT. So that kind of finding may tell you, add you some information about whether it is just pneumoconiosis silicotic nodule or some combination of mucus plug finding in the active tuberculosis. Probably Dr. Arif will add something about that.
Well, thank you, Prof. Umi. Before go to the profile list, may Dr. Somkiat answer this question based on your experience to do surveillance in Thailand, please, Dr. Somkia.
Okay, actually, in our country, we perform the surveillance by medical screening by use the plain chest X-ray and spirometry. That's it. If we got if the workers got some sign symptom, we refer to the hospital to confirm diagnosis with further diagnosis by other method.
Well, what's your answer, Prof. Rodney, please?
Well, Professor Rees and I work very closely, so he and I have exactly the same questions. But I suppose the problem there hasn't been sufficient research, and that research really should have been done in our part of the world, because you really need clinical radiopathological correlation. I think the general feeling is that when you have so much disease on the chest X-ray, you can easily miss active tuberculosis because it's the relatively subtle changes that take place over time. So you need continuous surveillance. Many of these people who are subject to screening live in rural areas. They don't have access to that sort of surveillance. And I think they're a very important group. And I think we need to find the resources to do that research so we can answer those questions. Thank you.
Well, a challenge from Prof. Rodney for all of us. Dr. Pralat, what's your experience about it?
Which one? Sorry, I missed it.
Yeah, about the comparison between the HRCT and plain radiology in detecting the tuberculosis and silicosis.
In our country, we do not take HRCT as a major surveillance. Actually, it's confined to the chest X-ray only. HRCT is mainly done for the purpose of excluding certain diseases, but not as a routine surveillance program. So we do not have much of experience of using HRCT as a surveillance measure.
Well, thank you. I chose another question. The other question, from Dr. Prem Kumar. to everyone, because I think this is the problem for most countries. The question is, most of the workers exposed to high dust are migrant or temporary workers, and work history is also not tracked properly. How can we relate with current employer organization which follow all protective measures and to follow up with relief and rehabilitation? I give the first to Dr. Wiwitana, please. Hello.
Oh, excuse me.
Dr. Wiwitana.
Can you repeat the question, please?
Yeah. Okay.
Dr. Muktia, shall I answer that question of Prem Kumar?
Prem Kumar, yeah. Most of the workers exposed to high dust are migrant, temporary workers, and work history also not tracked properly. How can we relate with current employer?
See, the migrant workers are a big problem in any industry, especially in the small scale industry dealing with the sandstone mines or the small mines or the stone carving industry, and where silicosis is quite prevalent. The problem with migrant workers is that they work from one unit to another unit, becomes very difficult, and presently there's no system of registering these workers. If they become like in Rajasthan, if they are working in the building and other construction workers, then they can register on the portal. But registration on the portal is based on the what we call domiciliary requirement. That means the person has to be the resident of the state in order to become the eligible for all the benefits. So it's very difficult to track, and these people keep on going from one place to another. Today they may be working at one place, going back to their hometown and coming after another 6 months. So it's a very difficult problem, and it's a problem basically with the small scale industry. And though in our policy we have said that any migrant worker, any worker for that matter, who has includes the migrant workers who has worked in Rajasthan, if he is able to prove that he had developed silicosis because of working in Rajasthan, we would provide him all the benefits of the state policy. But it's a difficult task. I must agree, it's very, very difficult.
Yeah, thank you. Yes, I
want to share this question.
Yeah.
Hello, I want to share this question. In our country, in Thailand, where we got the same problem because most of the workers are informal workers. They are work at home or work in community that I show in my presentation. So we try to develop the basic optional health service by integration optional health into primary care. So right now, when we train health officer in the primary care units to know about some kind of the optional health problem in their area, we set up the activity. For the first thing they need to do, we call the optional health profile. And if they have to survey occupation in their own catchment area in the community. And secondly, they have to perform we call the go to field visit or the workplace visit to get some information from some high risk worker. For example, if some statistic, the people in the community work for stone carving or some kind of the exposure to silica, they have to have the checklist to get information about what kind of the work, something like that. And then they can get information to what can I say, some kind we call the perceived activity, discuss with the workers. And then if they need to perform some dust measurement, they can contact the health officer from the provincial health office and some community hospital or regional hospital to perform medical surveillance. But anyway, health officer at the primary care can give some health education to the workers. And we also develop another kind of thing we call the health volunteer, especially for the migrant worker. We call the migrant health volunteer. We train them to know some basic knowledge about their optional health problem, and then can give health education to their own peer, their own workers in the same community or the same group of the migrant workers. This kind of the some kind of activity that can support empowerment of the workers.
Well, Dr. Viwatana, there are some important questions that you may answer. That question from Dr. Kiki, Indonesia. As you mentioned about the digital standard of radiograph, how to have or buy that digital standard, and also any training on it. And also it is related to the question from Dr. Supraj Kumar, India. Is the NIOSH reader training program available in India or Asia? I think Prof. Fumi also have a responsibility to answer this question, as you are a president of ERNIMU Asia. Yeah, first go to Dr. Viwatana.
Thank you very much. I learned from Dr. Sukarnuma that the edition 2022 is going to be online very soon, maybe perhaps even this year. And perhaps Professor Kunama knows better than me about this edition.
Well, Prof. Sukarnuma, Prof. Fumi, please.
So we are almost finished finalizing the new revision, and it's going to appear soon. But every time the Secretariat says that soon it's coming, but we were waiting for about
2 years now.
2, 3 years. So
4 years.
we're expecting to have 4 years maybe. So we are expecting to have that very soon. And if it is it is published, probably the images will be can be downloaded from the ILO website. But we do not have the detailed information right now. So we will tell you through the MinOSH network.
Yeah, that's a good opportunity for collaborating, and MinOSH scientific community is ready to support this program. Prof. Fumi. Yeah. Okay, thank you very much. I think that we have still time to look actually. Okay, by the participant who haven't got opportunity to get the answer, we will send. As far as you send the email address to the attendance list, and we may send the answer for your question. I think from Oki Fauzul Zakina, Indonesia. Yeah. Well, I'm wondering in what ways we are reaching these workers working in remote areas. Yeah, I chose this question because it's also the problem of most countries, or having problem with their status immigrant, as mentioned before and answered by Dr. Somkia, to cover a thorough surveillance. How far we are using behavioral, and the second is how far we are using behavioral change program to change workers' perspective in using personal protective equipment. I think Prof. Somkiat should be first, and then go to Prof. Erlich. Dr. Somkiat, please.
Yeah, I would like to respond to this question. Actually, it's quite difficult to encourage workers to wear PPE. Firstly, sometimes they have no knowledge about how to use it. Is the first thing. Secondly, especially in hot and humid country like in Thailand, when we encourage the workers to wear PPE, it's very difficult. It's not comfortable. They have to work in a hot area, and then it's very dusty. Sometimes they cannot decide to wear it for all time. And thirdly, PPE is quite expensive for them, because if they are the worker, informal worker, or in the community, they have to buy the PPE by themselves, and it's quite expensive for them, and they have to change it's not. It's we have to think about how to find the very cheap one, for the workers. But we have to come back to the principle that we have to prevent at source, not the PPE. It should be supplement. This is the question that I try to answer.
Oh, well, thank you, Prof. Rodney. Prof. Erlitz, would you please?
Yes, well, temperature plays a role. So Johannesburg is not particularly hot, but when you think that deep level gold mining goes down now to 5 kilometers underground, so it takes the miners longer to get to their sort of stope where they drill, then it takes probably a lot of people to commute in big cities. So it's 35 degrees underground, extremely high humidity, and the water being used to, the addition of water being used for cooling. I don't know the answer to the question historically. I think it's always been difficult to establish an effective PPE program in those conditions. But interestingly enough, in very recent years, the phenomenon that put this in the spotlight was COVID. So now there was an imperative really to use non-pharmacological interventions. And so it emerges that a number of the mines that, at least as they reported, have been reasonably successful in getting the use of FFP2 dust masks in place. So that's very much an impressionistic observation. But the gold mining industry, of course, is shrinking, and many of the miners who participated, gave evidence to the lawyers in the class action suit, indicated that it was many, many years before they were handed any physical PPE. They're quite late in their careers, the older miners. Thank you.
Well, thank you. Yes, it's a very challenging in doing screening as well as diagnosing the silicosis. Well, Dr. Prarat, before we finalize the session, would you please to pick some question that you think is very important, please?
Yeah, I think there's a question from David Rees. It says, does the relief and rehabilitation program include tuberculosis prevention treatment? No. The answer is no. We are all cases of tuberculosis are not included. But if silicosis is associated disease along with tuberculosis, he is entitled for all the benefits. There is already a tuberculosis elimination program which is underway in India, and under which the tuberculosis is proposed to be eliminated from India by 2025, and the government is pressurizing pressurizing for implementation of this program. So this has been taken at the highest level in the government of India under the Prime Minister, and this is very much there's a separate relief and rehabilitation program for the tuberculosis, but tuberculosis patients are not part of this particular program. So that would be the answer for this particular question.
Well, thank you, Prof. Jinki. Because of time limit, please.
Okay.
Back to you. Sorry
Thank you
for all of distinguished participants.
Okay, thank you, our speakers. Thank you, our audience, for all your questions. Thank you, Dr. Mukhtar and Dr. Prahlad as the moderators of the Open Forum. We hope Professor Suganuma and Professor Rodney that in the ILO classification that will come out for 2022, there is a special section on the unique experiences and context of migrant workers, informal sector, and the like, especially because there are comorbidities and shifting work experiences as well as multiple exposures. Okay, some takeaway from this webinar and additional information that MinOSH would like to emphasize. First, among the clinical complications of silicosis, as mentioned by our speakers, is tuberculosis, also called silicotuberculosis, a disease which is still a major public health concern in low and middle income countries. Hence, silicosis control program should be integrated with the existing national tuberculosis control program of any country. Second, in order to address the prevention of silicosis globally, the ILO and WHO have established the joint ILO and WHO Global Program for the Elimination of Silicosis, or GPES, with the goal of eliminating silicosis by the year 2030. Again, by the year 2030, silicosis should have been totally eliminated. This is the vision and goal. Third, thus prevention is also key to silicosis control. There was a discussion on PPE as a complement to the entirety of control strategies in silicosis control and prevention. But at the apex of control strategies are engineering control measures such as dust prevention. The WHO, under the Prevention and Control Exchange Initiative, in fact developed programs to train people in developing countries in the prevention and control of dust exposure in the work environment. Fourth, diagnosis and health surveillance, which have been discussed in this webinar, are essential components in eliminating silicosis. However, we would like to point out that surveillance should only be complementary to primary prevention. Primary prevention is still at the crux of any program on silicosis control and prevention. And lastly, as we have heard from all our speakers, silicosis prevention and control requires the strengthening of national capabilities and the establishment of national programs. Corollary to this, silicosis policy direction relies on the cooperation between industrialized countries, developing countries, and international organizations. And we hope that MinOSH and ICO will continue to be at the forefront of silicosis prevention. At this point, we would like to thank our speakers for your gracious time. Thank you also to all our audience for your enthusiastic participation. Thank you to the platform providers, led by Dr. Liem Jenfuk of Indonesia, the chair of the subcommittee of MinOSH on publications and conferences, and the co-chair, Dr. Gogilan, as well as Dr. Tohir of Simeo Refcon. I would also like to thank Dr. Eric Jors from Denmark, the immediate past chair of MinOSH, who started this series of webinars. To our audience from all fields in health, allied health, and other disciplines, may you bring whatever you have gained from this webinar to your own field of work. Only then can we say that this webinar has been successful. To close, I would like to reiterate our mantra. Occupational safety and health is a fundamental right of our workers. Every worker's life matters. No worker should be left behind. No country should be left behind. From the bosom of our hearts, from MinOSH and ICO, thank you and good day.
Still one left, Prof. Jinky, taking picture for all the participants. Would you please, Dr. Lim, to arrange, or Tohir, or Dr. Gogilan, to arrange taking picture, and please turn on of your camera.
Okay, Dr. Gogilan, maybe you can help us to documentation. Okay, I will lead the documentation for all. We have 4 pages here, and we'll count 1, 2, 3, and please stay. You're very best smile. Okay, 1, 2, and 3. Okay, this is the first. Please wait a moment. I will go with the second. Keep your smile. 1, 2, and 3. Okay, just wait a moment. This is the third. 1, 2, and 3. Wait a moment. And this is the last one. 1, 2, and 3. All right, thank you, everyone.
Thank you so much. And for those from the audience who would like to be a member of MinOSH, please go to our website. You are all welcome to be a member of MinOSH, and thank you so much. The webinar is closed.
Thank you. Thanks, Jinky. Thanks a lot for organizing the wonderful webinar.
Thank you.
Bye-bye.
And thanks, everyone.
Bye.
Bye. Thank you.
Bye.